So in this session, I'm going to be talking about how to achieve accessible, equitable eye care. Now, this topic is very close to my heart because of the work that I do. I work mainly in public health, and these are my disclosures. So I am the chair of the Public Health Committee at the World Council of Optometry. I'm an assistant professor at the International Centre of Eye Health, and I'm head of global program design at a social enterprise called Peak Vision. So again, I wish I was doing this with you in person, but I'm still very happy that I could be included on the program and can still speak to you guys this way. So a question that I have for all of you, and I can't be there in person, but maybe with a raise and a show of hands, would you describe yourself as a public health professional? Unfortunately, I'm not in the room, so if you don't raise your hand, that's fine, but just have a think about this throughout this session and just have a real, reflection on what do you think you describe yourself as? Do you think you're someone who works in public health? So public health may or may not be a familiar term. In the UK, we're called Public Health England. In the US, it's called Centers for Disease Control and Prevention, so CDC. And there's various different names for public health. I believe in Lebanon, there's a Ministry of Public Health. So this is just a brief slide to show you what public health describes. When someone mentions public health, what are they talking about? And over the past 2-3 years, maybe it's a term that we've become all too familiar with because of COVID-19 and the responses globally. So what is public health? Public health is defined as the art and science of preventing disease, prolonging life, and promoting health through the organized efforts of society. So that was the definition that was been given by the World Health Organization. Now I'll dig a little bit deeper, and epidemiology is the study and distribution of determinants of diseases in populations. Now it is the key quantitative discipline that underpins public health, which is often described as the organized efforts of society to prevent disease and to promote health. So why does public health matter? And why do we talk about it? And why am I so passionate about it? So, I'll give you an analogy. We expect that when someone cannot see, has some sort of visual impairment, they go through a system and they come out at the other end of the system, having been cured or having received the treatment that they need. But that's not what happens in reality. In reality, when you have a visual impairment, you go through a system, but you don't necessarily come out. So there's a leak somewhere, and this is often referred to in public health as the leaking pipe analogy. So in reality, what happens is when you have a vision impairment, you go through a system and you don't always get the treatment that you require. You fall out. Some may get through the system and come out at the other end, but some of them fall out. Now, let me explain that with experiences. I practice in the UK as an optometrist, and here are some of my personal experiences. So a patient presents at the GP with a headache. Most GPs recommend that the patient go see an optometrist, and that's the end of their duty. A patient is referred to the hospital eye service by me when I'm practicing, and I presume or assume that they'll reach the hospital for their appointment. A patient is advised of a treatment. They agree to it and comply with what is required for it to be effective. For example, a patient is told to use hot compressors and clean their eyelids. When they leave my practice, I assume they will do exactly that. But experience shows that such assumptions are far from the truth. How many times have you taken a history and symptoms only to find that the patient is struggling to see because they're not using their glasses as prescribed? or their eyes are still dry because they did not go and purchase the dry eye drops that were recommended. Now, whose fault or where is the weakness in all of this? You did your job as a clinician, you advised the patient what to do, but it turns out that they didn't go and access the treatment, or they didn't turn up for their referral. So ultimately, the patient doesn't receive their treatment and the problem continues. So a question that I usually like to ask is, have you heard of or read the World Report on Vision? Again, I'm not there to see the show of hands, but I'm hoping that you're all nodding or saying no at this stage. So, on October the 9th, 2019, on World Sight Day, the World Health Organization published the World Report on Vision. Now, this is a report that's key to informing and persuading global leaders about the magnitude and unacceptability of unavoidable vision loss globally. You may be very familiar with all these numbers. At present, there's at least 2.2 billion people around the world that have a vision impairment, of whom at least 1 billion have a vision impairment that could have been prevented or is yet to be addressed. So this report was produced at the request of member states during a side event to the 70th World Health Assembly. And with support from experts around the world, the report provides evidence on the magnitude of eye conditions and vision impairment globally. And also draws attention to the effective strategies to address eye care and offers recommendations for actions to improve eye care services worldwide. The key proposal of the report is for all the countries to provide integrated people-centered eye care, IPEC, IPEC, and services which will ensure that people receive a continuum of eye care based on their individual needs throughout their lives. So the World Report on Vision is directed at ministries of health, development agencies, civil society organizations, researchers, practitioners, and policymakers from the fields of eye care. So that's basically all of us. It's hoped that by shaping the global agenda on vision, the report will assist member states and their partners in their efforts to reduce the burden of eye condition and vision loss and achieve the Sustainable Development Goals, particularly SDG Target 3.8 on universal health coverage. So the core components of universal health coverage mean that all people have access to health services they need, when and where they need them, without financial hardship. So this is where we're coming to talk about accessibility and equitable access to eye health services. Universal health care is a global priority for the WHO and the underpinning of health-related sustainable development goals. The WHO's strategy for achieving UHC is to implement integrated people-centered health services. This means putting the comprehensive needs of people and communities, not only diseases, at the center of health systems and empowering people to make a more active role in their own health. The WHO have also made it very clear that universal health coverage cannot be universal without affordable, accessible, and high-quality comprehensive eye care. So this is where you start realizing that this is all about us as well. The core components of universal health coverage are often illustrated using a cube and are intrinsically linked to health financing. The inner cube reflects the budget constraints. To conceptualize eye health within universal health, this cube has been adapted. Universal health coverage is not a fixed final goal. Population health needs change constantly, and new treatment options are regularly developed, which present challenges for defining interventions and measuring impact. So this cube has been adapted from the WHO to contextualize to eye health services and includes the quality component. The inner cube has a color gradation representing a range in the quality of delivered services. The green represents effective quality services, and the blue represents ineffective services. So what does this mean? When the WHO advocated for the need for integrated people-centered eye care, this approach is to ensure that health systems are strengthened and should be the foundation for service delivery. IPEC refers to eye care services that are managed and delivered to assure a continuum of promotive, preventive treatment and rehabilitative interventions against the spectrum of eye conditions, coordinated across the different levels and sites of care within and beyond the health sector, and according to their needs throughout the life course. IPEC will be a way of achieving universal health coverage. Now, these are lofty words, lofty goals. What does it really mean when we say continuum of care throughout a health system and at all levels? So again, IPEC is defined as services that are managed and delivered so that people receive a continuum of health interventions covering promotion, prevention, treatment, and rehab, to address the full spectrum of eye conditions according to their needs, coordinated across the different levels and sites of care within and beyond the health sector, and the recognition that people as participants and beneficiaries of these services throughout their life course. So let's think about it in terms of our patients. At each stage of this process, from identifying a patient, diagnosing them, giving them a service, and then realizing the impact. At each stage of this process, the number of people reduces. At the same time, the level of training and expertise required increases. So, to identify that someone has an eye health problem can be done by non-eye care professionals as well. It could be done by community health workers, specifically trained screeners. But as you get further down the system, you need specialist services such as optometrists, refractionists, ophthalmologists, and other allied eye health professions. Now, identification and screening, like I said, can be performed by non-specialists, and it can be done in schools, communities, and can be done on a large number of people. Of those people that are people that are screened, only a smaller number of people will require the treatment. And this will have to be done by highly qualified doctors or optometrists. This means that scarce specialist resources can be focused on those who need them the most. What it also helps us do is better understand the outcomes at each stage where people are being lost to treatment. For example, what is happening through the system? A patient was recognized as having a problem, diagnosed, and then advised to go access a service. But the patient gets lost in this pathway because maybe they didn't attend their hospital appointment, or they didn't come back for their fitting of their glasses. So, to address population eye care needs, all levels of this care needs to be integrated and have effective referral pathways. There is no single path that countries can follow to achieve a strong primary eye care that includes primary care that includes eye care. The path may include the integration of primary eye care services within primary healthcare centres, achieved through enhanced supervision and the training of existing staff, or the adoption of standalone primary eye care services either in fixed facilities or through mobile units. So the key components of the information building block include the development of a health information and surveillance system, the use of standardized tools and instruments, and the collation and publication of national and international health statistics. These components make it possible for strategic use of information and the research on health and health systems. So a well-functioning health information system ensures the production, analysis, dissemination, and use of reliable, timely health information by those who are making health policies and managing and clinical decision makers on a regular basis. So as presented in this figure, health information systems covers 3 domains: health determinants, health systems capacity, and performance. So that's the inputs, outputs, and outcomes, and health status. So let's dig into that and try and understand what this means, because this all sounds very complicated. So delivery of healthcare is very complex, and the notion of universal health coverage and how to measure it is multifaceted. So we just need to understand, what should we measure? Now, there are 3 key data points that will help us better understand whether our health systems and the services we're delivering are achieving universal health coverage. So are they accessible and are they equitable? So what you need to understand is the unmet need, the met need, and the barriers to healthcare. And these can be translated into measurable parameters of a service, namely coverage, adherence, and effectiveness. What I'll go on to do now is to describe what that means. So with this end-to-end approach, it's possible to measure the most sensitive system variables for achieving universal health coverage. In other words, of those with an unmet need, how many have had their need met? And for those that don't, why not? Okay, so coverage, with an unmet need, what proportion identified either through screening or self-identification, and that will give you the number for coverage. Adherence, so of those that you identified with a need and referred to the next point in the health system, what proportion actually make it to where you want them to go? And effectiveness, of those who receive an intervention, what proportion has the intervention worked for? Now, I'm not even talking at this stage about the medical treatment having an impact. What we're trying to fully understand is, if a patient requires a treatment, have they actually even received it and complied with it? For example, glaucoma eye drops. You prescribe them, but does the patient go on to then continue to use them? So we'll work through an example. You screen a population, so that's 100%, 100 there. And through that screening, you identify that 80%, so 80 of those require a service. You identify 80 of them as having an eye problem. 20 of those you haven't even actually managed to identify. And that could be for various reasons. You held a mass screening, people didn't come for the appointment, or there are people who don't know they have a problem and go and access a health service. So, in other words, 20% are missed. And importantly, what we can try and understand of those 20% that are missed is, what are their features that differentiate them from the 80% that are not missed and picked up. Right, so this next stage, adherence. The adherence at 50%, typically actually program reports show that typical adherence is 10 to 20%. We're being a bit generous here. Of those 80 that you identified at screening as having a problem, only 50%, so 40 of them, turn up for their treatment. The other 40 do not adhere to their referral. So you're now starting to get the picture that people fall out at each stage, and this number starts to get smaller and smaller. Okay, and the effectiveness, okay, so of those 40 that turned up for their treatment, okay, 75% of them, the intervention has worked as intended. And so what this does, if you look at your whole system, it gives you an overview of 30 of the 100 that actually needed a treatment had their need met. Now I'm going to leave this up for a second for you to just understand how important it is that you try and understand the effectiveness of whatever your practice is. So 100 people had a problem, you only found 80 of them. Of the 80, only 40 of them actually received their treatment, and then of those 40, only 30 of them had adhered to their treatment, or the treatment was effective for. So now you start to build up this picture of how many people are you actually missing when you're working, or when you're trying to practice or trying to identify those with a vision impairment. So we know that there's an increasing population and an aging population, and there are environmental changes, lifestyle changes, and what this is going to do is lead to a dramatic increase in the number of people with vision impairment and blindness. So those are the people, those are our patients. Okay? Now, the World Report on Vision talks about us, optometrists, in many ways. And some of the quotes that I found from it will help you understand why it's really important that we as a sector start to work together. So it talks about optometrists in places as uncoordinated and unregulated workforce. And it says several factors accentuate the problems associated with the shortage of health workers in low and middle income countries. These include suboptimal distribution, both geographically and across income levels, issues with retentions, poor supervision, and coordination of eye care services amongst health workers, which can often result in parallel services, overlap, inefficiencies, and gaps and poor outcomes. It also goes on to say, although the private sector makes up a significant proportion of the provider landscape, nobody really understands how much the private sector is contributing for the prevention of blindness. It also mentions, while innovative strategies have emerged which use community-based workers and other cadres such as optometrists to deliver eye care and vision services, their impact has been hindered by a lack of coordination, regulation, and a systematic integration, resulting in persistent service gaps and inequalities and a lack of standardization of care in many low and middle income countries. And so while a significant amount of progress has been made in the promotion of training standards for optometrists, optometric technicians and optical technicians, the acceptance of optometry as a profession remains an issue in many countries and is an important advocacy issue going forward in many countries. It also says, in this context, it's important to note that in some countries, productivity may be diminished because a section of the healthcare workforce, such as optometrists, are not accredited to carry out eye care services independently. Now, these are all quotes from the World Report on Vision, but why I wanted to share this is because we need to really come together as a sector. If we want to be a part of the journey for achieving universal healthcare, universal eye healthcare, to make services accessible, equitable, then we need to be aware of our gaps, our limitations, and come together as a sector. A recent review of health system dynamics in Trinidad and Tobago revealed that private sector optometrists and ophthalmologists provided 80% of all eye care, while less than 20% of the adult population were reported to have health insurance that covers care provided by the private sector. So this helps to build a picture which isn't just for Trinidad and Tobago. I think this is valid for many settings, that there's a lack of health insurance, there's a lack of public health care services, and so patients are going untreated. So there was another very a landmark publication, and that was the Lancet Global Health Commission on Global Eye Health, and this covers the current scale and cost of impaired vision while assessing potential solutions. Now, this is available online as a soft copy. I'm not quite sure, but I'm hoping that some hard copies will be available for you maybe throughout the day or later on as well. So fingers crossed those will have reached you. I'm not going to read this all out, but what I really wanted to share to encourage, to get a discussion and a conversation going, is that as optometrists, we have to recognize that we are part of a system. Now, the Lancet Commission recognized there are 3 types of people who need eye care. Those who need ongoing care, those who have early stage disease, and those who have symptoms that don't cause a vision impairment always, but require services. As optometrists, we can support all 3 of these groups. And if we can further work together as in a team approach with either ophthalmologists or other eye health professionals, technicians, those who have other skills, then we will be a part of this journey. Currently, optometry is being recognized on a global platform. We are being included within eye care plans, within national strategies. What remains a challenge, though, is internal for us, because we need to start thinking about regulatory services. We need to start thinking about our limitations, and we need to start to become one voice as a sector. Optometry needs to improve its role in public health by recognizing the social determinants of eye health and visual impairment and the link with quality of life and mental health. Basically, what this also means is we need to start looking broader. When we have a patient sitting in front of us, the only way we will ensure that they have access to good eye health services and that they are and equitable services is if we start thinking about that patient as a holistic. If we start approaching our patients with a holistic approach, then only then will we serve our patients the best. We need to embed data collection and make decisions which are evidence-based within our practices to make sure, at the same time, tackling the challenge of building quality services and standardizing the care that we provide. We need innovative approaches to education programs, continuing professional development, especially in countries where optometry is a young profession. And I cannot emphasize this enough. We are at this crossroads where we have the opportunity to contribute to something that is much bigger than us, to a larger global problem, to a problem in our settings that we are definitely qualified to do and competent enough to do. I want to just share very briefly that there's been global commitments to eye health and universal health coverage over the last few years. There's been a United Nations political declaration, there's been a World Health Assembly resolution on integrated people-centered eye care. Most recently, there's been a World Health Assembly global targets on eye health, and these are massive milestones and major achievements for the eye health sector. We need to harness these opportunities and be part of the conversation. And most recently, at the Commonwealth Heads of Government meeting, there was a commitment by the leaders to provide good quality eye health for all children. And countries have signed up to this. A commitment has been made. So in summary, as optometrists, we are public health eye care professionals. We need to base our practices on evidence, and that means we need to collect data, analyze it, disseminate it, and make sure we translate it within our services, because that will help us improve the programs that we provide and increase access to eye care services. We need to be working together. We need to enable eye health providers globally with a standardized way to measure their work, improve the services, and we need to collect the data. We need to, in our own practices, collect data on things like coverage, things like adherence, effectiveness. What are we doing that is helping us achieve this goal? Eye health and universal health coverage go hand in hand. Universal health coverage will not be achieved if eye health services are not equitable and are not accessible. So thank you very much, and again, my apologies for not being there, and I sincerely hope and wish the best for all of you and hope the conference goes well. please do contact me. These are my email addresses. And again, thank you very much for allowing me to speak and share some of my thoughts today.